So as Jane said, I'm a consultant transplant surgeon at the Manchester Royal, and thanks very much for asking me to speak. So I understand that there are a huge number of people here today, and your journey along the road with polycystic kidney disease could be at the very beginning. So you could be have just been diagnosed, and hopefully then transplant is a long way into the future. Or you may be somebody who's had a transplant and has gone through the process and is very familiar with the whole process. And this may be a quick recap. Either way, I thought I'd start towards the beginning. I'll go through everything in as much detail as time allows, but apologies if you've been through this and you know a lot about this already. I thought it'd be best to start from scratch. So what is polycystic kidney disease? Essentially, as you know, it's a genetic condition that leads to large cystic kidneys. And cysts are small fluid-filled balloons or capsules that overtake the kidney and replace the normal architecture of the kidney with these fluid-filled balloons. It's the 5th most common cause of end-stage renal failure, and more often than not, it's inherited. And if you look at these pictures, on the left is a normal-sized kidney, and a normal-sized kidney is about the size of your fist. Okay, if you make a fist, that's generally the size of your kidney, perhaps slightly bigger. A polycystic kidney that's been overtaken with these fluid-filled cysts can become huge and can be 30 or 40 centimeters from top to bottom. So really take up, and you imagine if you've got 2 of these within your tummy, they can become really, really big and stop working. So you end up with kidney failure. What I will do is go through the process of why polycystic kidney disease causes a problem, how we pick this up, what you can do to try and avoid some of the complications with this, and then the process of transplantation. And then even after transplantation, how best do we look after you and how to look after yourselves. So what problems do polycystic kidneys cause? Well, these can broadly be divided into those related to the kidney and those related to everything else, the rest of your body. Specifically to do with the kidney, they can cause a lot of pain. Okay, so you may get flank pain. They can cause, very commonly, water infections, so urinary tract infections. You can get bleeding into the cysts that often presents with pain. The cysts themselves can become infected, causing you to become quite unwell, have temperatures, have pain and tenderness around the side where your kidneys are. They predispose to kidney stones. And as you know, in the long term, it can lead to kidney failure. It can also lead to pressure symptoms. As I said, these kidneys can become very, very big. And if you've got 2 kidneys that are huge within your tummy, it can lead to pressure symptoms that can lead to abdominal bloating. Some people say they seem to walk around with a pregnant abdomen or pregnant tummy for a lot of the time. But that can become more severe because it can compress your bowel and stop you eating and drinking normally.
Hussein, can I just jump in at that point?
Yes, of course.
While you were talking about large kidneys, there was a question from earlier on today. This person was concerned about them having very, very large kidneys, yep. And whether they'd need to be removed prior to transplant. I'm sure you'll come on to that, but I just thought I'd mention it whilst you're talking about size.
That's fine. Briefly, yes, that's a concern that they may need to be removed. I'll come on to it in slightly more detail later. So is that okay? I'll come on to that specifically.
Thanks.
The extrarenal, so everything other than the kidney, what can happen? So they can cause high blood pressure, abdominal bloating, so bloating within the tummy and sort of tummy distension, as I've said. You can get aneurysms within the brain. Now, hernias are very common, and hernias are a weakness of the muscle. So commonly in your tummy, that can cause a split in the muscle and a split in the integrity of the tummy. And you then get lumps and bumps within your tummy. Now, they seem to be more common in patients with polycystic kidney disease. The reasons for this we're not entirely sure, but it's important because if you're having any major surgery, especially on your tummy, then you are more prone to develop these weaknesses and hernias that then may need further surgery. You can get problems with the valves in your heart. You can also get diverticulosis. Now, diverticulosis is an outpouching of parts of your large bowel. Okay, so essentially weaknesses within the bowel wall that then cause outpouchings. And these can be quite common and more often than not don't cause a problem. But occasionally they can bleed or cause infections and you may require surgery for these. And it is associated, some types, with diabetes as well. That, again, is a separate disease that can cause problems with your kidneys. So I know there's been people, you would have heard about this before, but I think it is worth stressing, because it's important to transplantation as well. And management of the polycystic kidney disease is not just about the kidney, it's about looking after everything else. So it's about checking your blood pressure and ensuring that that's maintained within normal limits. There are specific medications now, and your kidney doctors will be much more familiar with these, but one of them is tolvaptan, and that in some cases can slow down the progression and the development of these cysts in patients with polycystic kidney disease. It's important you stay well hydrated, you stop smoking. Exercise is incredibly important, and I'll come on to the stress of surgery, but especially around the time of surgery, to be as fit as possible is incredibly important in how well you recover. Diabetes is related to polycystic kidney disease, but you may have other medical conditions as well. And it's really important that all of these are optimized and assessed, so you're in the best possible condition when, if you need dialysis or undergoing transplant. And your diet is, of course, incredibly important. So transplantation and looking after yourself is much more just about looking after your kidneys, but holistically as well. So progression of renal failure, and how do we define this? And when will you come to see a transplant surgeon like myself? Well, your kidney function is measured by something called estimated glomerular filtration rate, or EGFR. And really normally that's about 100. So we call it a percentage. Okay, broadly speaking, your GFR is about 100. So if we convert that to a percentage, we'd say really normal kidney function is about 90% and above. Once your kidneys start failing, then the EGFR, or the percentage that your kidneys are working, slowly falls. Less than about 30%, we'd say that's a severe loss of function. And at about 20%, you should probably start to be seen in the pre-transplant clinics or the pre-dialysis clinics. And that's where your nephrologists or kidney doctors and specialist nurses will be looking at what types of dialysis would be most suited to you, and whether they think you'd be suitable for transplant. We would hope to see you before you start dialysis, so that's about a GFR of about 20 to 25, to assess whether you're suitable for transplant. You can only get on the transplant list when your kidney function is at about 15%. Okay, you may still not be on dialysis, and in an ideal world, we'd transplant you before you ever need dialysis. But you wouldn't get on the transplant list until your function is about 15%. So that's the passage through progression through renal failure. As well as transplant surgeons, we are involved with preparing you for dialysis. So you may see us before you are assessed for transplant for either insertion of your peritoneal dialysis catheter or creation of a fistula for hemodialysis. Okay, and that's just briefly to say that you may see one of the transplant surgeons wherever you are in the country for either of these procedures as well. So the benefits of transplantation, people often find it odd that we need to talk to you about the benefits of transplantation, but these do vary depending on how old you are and how the kidney failure is affecting you. But almost for everybody, you get an improved quality of life compared to dialysis. Whether you're on peritoneal dialysis or hemodialysis, you are tied to a machine, tied to regular hospital visits. You're unable to do most of the normal things that you would like to do. With a kidney transplant, we really do aim to get you independent of dialysis and get you back to as normal quality of life as possible, including travel, sport, back to work, living as independently as possible. We also say there's an improved life expectancy. Now, this varies depending on age. If you are 20 years old and require a transplant, we of course expect the kidney transplant to give you a much longer lifespan than if you were on dialysis. If you were 70, however, then the improved life expectancy is slightly less and potentially may not even be there when compared to dialysis, but we'd certainly give you a better quality of life for the next 5, 10, 15, 20 years, however long you're going to live. Now, dialysis itself is related to lots of complications. It causes your body to become more inflamed, which puts you at higher risk of things like heart attacks and strokes. So if you have a transplant, you no longer have dialysis, your body's inflammatory state, so the risk of you developing chronic inflammation, slows down and settles down. So you have a reduced risk of those complications. In children, transplant improves the growth and development of children. Okay, and there's a huge benefit for children to have a transplant. And if you're looking at the bottom line, then it's much more cost effective for any healthcare system for patients to be transplanted rather than dependent on dialysis. Now, there are complications of transplantation. These will be, whoever's speaking to you about transplant will go through these with you in great detail. I think it's important to include these in these talks so you are aware of them. And really, the more times you are told about these, the more chances you have of discussing them. Hopefully you become more familiar with them, but also slightly reassured that the vast majority of people who have a transplant go home with a good working kidney and have a much better quality of life. However, there are always bumps along the road, and some of these complications are just minor bumps that we need to get through. Others are slightly more severe, and I'll go through them. So specific to transplant, specific to the operation and the kidney itself, there's always the risk of bleeding, and occasionally patients need to go back to the theatre to have the bleeding stop. And we'd say about 5 out of 100 patients would have to go back to theatre to have the bleeding stopped. One of the most common complications after any surgery, but especially after transplantation, is infection. Related to the surgery itself, you can get an infection in your wound, in your chest, so chest infections, okay, because you've had a major operation and you've been to sleep and your lungs aren't working as well as they should be, or in your urine. Now, you will have a catheter, which is a bit of plastic tube that goes into your bladder and measures how much urine you make after surgery. So that's an area of focus for possible infection. Specifically after a transplant, we give you drugs that lower the effectiveness of your immune system. Now, your immune system normally fights infections, but we don't want your immune system to be overcharged after a transplant. So we give you medicines to stop you fighting the organ. But the downside of these, you become more prone to infections. Okay, and that's a problem in the short term, but also in the much longer term. You can develop urinary complications. Obviously, your kidney produces urine, and your kidney produces urine. It gets taken from a pipe down to your kidney into the bladder, and we make some stitches between the kidney and the bladder. Those stitches can either leak, causing you to have a urinary leak and perhaps having to go back to theatre, or in the longer term, that tube can narrow, causing your kidney to become backlogged, okay, and waterlogged, and that may require further interventions in the longer term. Rejection is something that everybody worries about, quite rightly so, and I'll go on to reasons for rejection in a short while, but it's where your body fights a foreign object. Okay, and about 10%, so 10 out of 100 patients will have an episode of rejection within 6 months. It doesn't mean you lose the kidney, and now our anti-rejection medicines are so good, quite often it may mean that you come into hospital, you have the rejection treated, and then you go home with a good functioning kidney. One of the most common complications after a kidney transplant is delayed graft function, or a sleepy kidney. That's where the kidney doesn't like being taken out of somebody, put in an ice box, and then being taken out and put in somebody else. So it gets stunned and goes to sleep. A sleepy kidney often recovers within a couple of days, occasionally weeks, and very, very rarely a bit longer. But we'd expect most of them to work normally after a short period of time. Very, very rarely, they don't work at all. And less than 1 in 100 kidneys wouldn't work at all. We'd call that non-function. Again, very, very rarely, you may not survive the first year after a transplant. Now, that really depends on a huge number of factors. And as I say, most people go home with a good working kidney. Okay.
Hussein, can I ask? Sorry, I'm sorry to jump in. If you could perhaps dispel this one, it came up earlier actually. This person's asking how long you should be on dialysis before transplant, which of course, if you can perhaps explain that one.
So how long should you be on dialysis before transplant?
Yes, I think this person is believing that you must be on dialysis before you can get a transplant. Okay,
so no, you don't need to be on dialysis, and ideally the best outcomes after a transplant happen when you never get on dialysis. So as I said earlier, the GFR, or the function of your kidney, at about 15%, you then become eligible to get on the transplant waiting list. Now, most patients wouldn't need dialysis until your function gets to about 10%. But that's something that you would discuss and see how you feel and what your symptoms are like, and you discuss with your kidney doctors. So there is a window there for you to be transplanted before you're on dialysis, and that's the ideal window to be transplanted. Now, if you have a live donor, that can be controlled, and we can certainly plan so that when your function is between sort of 10 and 15%, we can do the live donors, stopping you going on going on dialysis. But if you are on the national waiting list and the wait time is about 3 to 3.5 years on average, you can only be put on and activated when your renal function is about 15%. And if your function stays level at about that for the next 3 or 4 years and you get a transplant, you could have a transplant without ever being on dialysis, and that would be great. But if your function deteriorates quite quickly and you end up on dialysis, then you are on dialysis for a short period or for a period until you get your transplant. But you certainly don't need to be on dialysis before you're transplanted.
Thank you. This person's asking about any statistics regarding death for kidney recipients and or kidney donors.
Okay, so for kidney recipients, overall about 5 in 100 don't survive the first year after a transplant. That's really dependent on a huge number of variables. And of course, if you are young and otherwise fit and well, your overall survival would predict it to be much, much higher. Okay. If you are towards the older scale, in your late 70s or 80s, or if you have a number of other medical problems, then it may be slightly higher. But overall, we'd say that your risk of not surviving the first year is 5%. Okay.
Thank you.
Okay. All right. The other is specific to the medicines that we give you. And as I said, we give you the medicines to try and lower the efficiency of your immune system, to stop you rejecting the organ. And it's a balance really between rejection and then the risks of the immunosuppression that we give you. But there are increased risk of infection, cancers, and those cancers actually tend to be fairly benign skin cancers that are easily treatable. Occasionally you can get much more severe blood disorders and blood cancers, but thankfully they're quite rare. And you do become more prone to diabetes as well. So we will keep a regular eye on your blood sugars in the long term after transplant. And finally, there are a couple of risks that are extremely rare, but you do need to be aware of. And in deceased donor transplantation, we obviously we know a limited amount about the donor. We do a number of tests checking for viruses. We take a full history from relatives and GPs and doctors that have known them about cancers and previous infections that they've had. So we try and minimize the risk of infection or cancer from the donor to the recipient. But there is a very, very small chance that we've missed something, okay, and something can be transmitted. In most situations, if there's a specific concern, then we'd discuss that with you, okay, and we'd have a chat with you as to whether you would like to take that risk and how real that risk is, okay, but that's incredibly rare that there is a transmission of infection or cancer. And with any surgery, really, not just transplant, but there is a risk that we can damage some of the surrounding structures when we're operating. But again, thankfully, that's very small. Okay, so the path to transplantation. The nephrology assessment is where you see your kidney doctor, or the transplant specialist nurse, the kidney specialist nurse, and they will assess you from their point of view as to whether they think you are suitable and fit and whether you will benefit from a transplant. They'll do a number of tests, including blood tests and tests to check whether your heart and lungs are working efficiently and effectively. And then they will send you to your nearest transplant unit. So in Manchester, we get referrals from all around the Northwest for patients who want to be considered for transplantation. Here you'll be seen by one of the surgeons, together with our specialist coordinators, and all being well, you'll be waitlisted on the transplant waiting list. And as I said, the average wait time is about 3 to 3.5 years in the UK. Okay, and it's a national waiting list. So if you're on in Manchester, it's not just a Manchester waiting list, you're in a national waiting list waiting with everybody else. But obviously your operation will be in Manchester if that's what you're seen, or wherever you've been seen by the transplant surgeon. And then you go to transplant. And I'm going to briefly talk through this whole process before we get to transplant. I should say, and I meant to start this, I've got photos of the operation itself, so I'm quite glad this is after lunch, But do be prepared that there are some photos of the operation itself, just to talk you through the steps that we go through. Okay. So what's the criteria for transplant? And strictly speaking, these are patients who are currently on dialysis, so renal replacement therapy, or those predicted to be on renal replacement therapy within 6 months. And that's defined as a glomerular filtration rate or a percentage of 15. Okay. Now, it's broadly speaking within 6 months, but you could have a 15% kidney function for a lot longer than 6 months. Okay, but if it's less than 15, then you are eligible to be on the transplant list. And you do, of course, need to be fit for transplant. And that's really the large part of assessing you for transplantation. So the aims of the assessment are firstly to identify who wants a transplant. It's rare, but it does happen that some patients don't want to be put forward for transplant and are happy on dialysis and happy with their quality of life. Who will benefit from transplant, who fits the criteria, who will survive the peri-transplant process. Okay, so who's fit to really undergo that major surgery and then the drugs that we give you in the follow-up, and who will comply with transplant follow-up. And that's patients who we know will comply, because the follow-up is almost as intense as dialysis itself for a short time before becoming much easier. And you need to be able to comply with the transplant follow-up. And I'll briefly talk about what that is later. So the assessment process is done by not just one or two people, but by a whole team of people. You've got the patient, your friends, family, carers in the middle, okay? And it really is important that it's not just you as the patient, but that friends and family are involved as well, because you do need a really important social support to help you through this process. As I've said, there can be a number of bumps along the way. You are seen by the transplant surgeons, our specialist nurses. You will hopefully see the live donor team. Okay, you'll be assessed by them if you've got live donors. And you may not be seen in face by, but the transplant laboratory will have a lot to do with matching you and being sure that the right donor goes to the right patient. In addition, you've got the medical team on the left-hand side. You've got the nephrologists, who are the medical kidney doctors, the nephrology specialist nurses, and the pre-dialysis or pre-transplant teams. And that'll either be at your base hospital and or at the transplant center itself. Now, more and more now, because we realize that transplantation is a major undertaking, you may or may not be seen by the anaesthetists, who are the specialists that put you to sleep and look after you around the time of surgery, because they are really integral in assessing whether you're fit for transplant. And you will probably be seen by a pre-op team. And the anaesthetists with the pre-op team are there to try and help get you in the best physical shape before your transplant. What we'll do when you come and see us in hospital as a transplant surgeon is we will obviously understand the cause of your kidney disease, and we'll take a full medical history. That would include dialysis, whether you've ever been on intensive care and why that may be, and previous surgery. Now, sensitizing events are events that make your immune system more likely to have antibodies, and antibodies are the cells in your blood that predispose you to rejection. And these events are blood transfusions, transplant history, and pregnancy. So any medical event you've had where you've had a foreign object into you, okay, that's where your body can produce these antibodies and put you at a risk of rejection. We will want to know about comorbidities, so other medical conditions that you suffer from, anything at all that may impact not just on the surgery itself, but on your workup and your fitness for surgery and how we look after you afterwards. It is more individualized depending on what are the medical conditions you may or may not suffer from. We'll take a family history, again, a social history, and we'll want to know what medicines you're on. Okay, specifically whether you're taking any medicines that thin the blood, because that may make you at higher risk of bleeding, and we'll need to take that into consideration around the time of surgery. We'll also examine you. And a question about having large kidneys, I'll answer here. So on the right, we've got a CT scan of somebody with polycystic kidney disease. Now this there is your left kidney, or is a left kidney, and this there is a right kidney. Okay, now these are huge polycystic kidneys, and all these black dark areas here, these are all cysts. Okay, this white area here would be normal kidney structure. So you can see there's very little normal kidney structure left in these kidneys, and they've almost entirely been taken up with cysts. And the cysts are so big that they almost entirely take up the whole of the tummy. Okay, that's your pelvic bone, and that's your liver up here. So the kidney on the right stretches right from the liver down to the pelvic bone here. Now we put a kidney in around here, just above your pelvic bone. So when we examine you and you've got polycystic kidney disease, one of the biggest things that we will want to do is to assess whether there's space, either on your right or your left-hand side, to put a kidney in. We'll almost always do a scan, but actually the clinical assessment is much more useful. And we find that most people will have some space, and we'll be able to find space either on the left or the right. Very, very occasionally, if we feel that you haven't got space, then we will need to take out one of the kidneys. Okay. If that happens, that procedure will have to be done before you are listed for transplant, and we would go through that with you. That's one reason for taking a kidney out. The other reasons are if they're causing huge mass effects. So occasionally we've had patients that actually can't eat and drink enough and can't sustain themselves enough because the kidneys are so big, they can't take enough nutrition. Okay, so we've had to take a kidney out for them to increase the size of the stomach. On this scan, that is the stomach, and you can see it's actually very, very small. So you'd become very full very quickly. So we may decide to take the left kidney out to give the stomach more space, to allow them to eat and drink more and put some weight on. That would be another reason. If they're causing infections or if they're bleeding or they're causing a lot of pain, we may discuss with you about taking one or both kidneys out. Okay. We'd also examine your heart and your lungs, but we would have investigations that would give us an idea, an objective assessment of how well they're working. So we do blood tests, and they would be simple blood tests like your full blood count to check what your blood levels are like, whether there's any infections on board. We'll do a cross-match blood test, and I'll explain the next slide more specifically about why that is so important. We may do imaging of your native kidneys, as I've said, to assess for space for transplantation, and we'd assess your fitness. And when we say that, we're really looking at your heart and your lungs to check that they will have the reserve to cope with the time around surgery and to make sure that you're in as best possible condition when you undergo major surgery. Almost everybody will have an ECG, a chest X-ray, and a heart scan, an echo scan, which is like a jelly scan of your heart. And occasionally, we may ask for an angiogram, which is a dye test, to look more closely at the blood vessels going to your heart. And very rarely, some units, and in Manchester we use quite a lot of this, you'd have to undergo a bicycle test, which is a CPET test, that puts you on a bike, gets you exercising, and looks at how well your heart and lungs are doing on an exercise test. So what is cross-matching or organ compatibility? This is a minefield to me, and people much cleverer than I am look into this in much more detail, but this is my understanding, and hopefully this is a useful way of looking at it. So each of us has an individual genetic profile, like a barcode. And if you had an identical twin, they'd be the only person who'd have the same barcode of the same genetic profile as you. So we each have an individual genetic profile. Now, your body, immune system, contains cells that scan for foreign barcodes, because each cell in your body has your own barcode. If for some reason you're given a foreign barcode, your immune system will pick that up, and it has cells to pick that up. And it will then produce antibodies to try and fight that foreign object, be it pregnancy, transfusions, and transplantation, organs. The more of these antibodies you have, the harder it may be to find a suitable organ match. Okay. While you're on the waiting list, our transplant lab will check regularly your blood to check that you've not developed these antibodies. And it's so much more important if you've had blood transfusions, or you've had pregnancies or previous transplants, that we keep a track on what antibodies you have in your blood. Now, prior to transplant, when we've got the specific donor and the organ for you, this antibody testing will be done this cross-match will be done to check that you've not got antibodies that will specifically fight that organ. And therefore, if you did have those antibodies, it would be a very high chance of rejection, and we therefore wouldn't go ahead. Okay. So once you've been through all that, most people will then be put on the transplant list. In some situations for a kidney transplant, if you are considered slightly higher risk, or there's something that the surgeon assessing you is slightly uncomfortable with, you may be taken and discussed, your case may be taken and discussed as a multidisciplinary team. This is essentially where a group of transplant specialists, nurses, medics, pharmacists, and surgeons. And in Manchester, we have an external chair to make sure we're being as objective as possible. And we'll sit down and discuss the case. And if ever you were going to be denied a transplant, your case would be discussed here first. So it's not just one person who's the gatekeeper to transplantation. Okay, we want to make sure that we give everybody an equal opportunity to get on the transplant list. Very rarely, patients just aren't suitable, and that decision is made at the multidisciplinary team meeting. So before I get into the transplant itself, I briefly wanted to talk about the types of donors. And broadly speaking, there's two types. There's deceased donors and there's live donors. Live donors are commonly friends or family that will come forward and offer to donate to you. Occasionally, they can be complete strangers who want to do something altruistic and donate a kidney. But deceased donors are split into two, either DCD or DBD, and that's really defined by how we define death in the UK and internationally. Okay, most people think that death is defined when the heart stops, and that's the most common way of defining death. And yes, the heart stops, and that's when we define how someone has passed away. But you can also die when it's something called DBD death, so brainstem death, and that's where the part of your brain that controls you breathing and your heart beating has died away. And there's specific tests that we can do for that. But in that situation, your heart continues to breathe and your heart continues to beat and you continue to breathe because of the machines that the donor is on intensive care. And the reason I say that is in brainstem death, because the heart and the lungs continue to function, although with machine support, but the brain has died, the donation almost always proceeds. There are occasionally times where it doesn't. So if you are getting an offer from a DBD donor, you're very likely to end up having the transplant as long as the cross-match is okay and the organs are okay on inspection. However, after a donation after circulatory death, we have to wait once all the machines have stopped for the heart to stop beating. And that can be very quick, or it can take a lot longer. And if it takes too long, then we wouldn't retrieve those organs. And that happens in about 50% of patients and donors. And in that situation, you may be called into hospital. You may go through the workup in hospital at the time of transplant and then it not proceed. And that may be because the donor was a DCD donor and they haven't passed away within the specified time. So I hope that helps explain why things may not proceed. So you get the call, you've been on the transplant list, you get the call, it's often one of the specialist transplant coordinators, and these are the sorts of things that they will want to know. It's often in the middle of the night because that's often when a lot of the offers come through. But they'll want to know if you've been through the process before, what kind of medicines you take, do you dialyse, when you last had something to eat and drink, can somebody bring you into hospital, and just to make sure that everything at home is okay, do you have kids, do you have pets that need looking after? Okay, so these sorts of plans need to be put into place. It's not often that you have to come in urgently, but you'll need to come in within a reasonably short space of time. So once you get into hospital, you'll be seen by the surgeon, the anaesthetist, and the medical teams to make sure everything is okay. Blood will be taken, and we may need to dialyse you if you would do dialysis on that day. You'll have a chest X-ray and an ECG, which is a reading of your heart to make sure that there are no concerns. We will wait for the cross-match report, and the organ will arrive to the hospital. We will take the organ to theatre, and we will check that we are happy with the organ, that there's no damage, that it's as healthy as we were hoping for and that we've been told. And at that point, you'll be taken to theatre. You'll be put to sleep in the anaesthetic room, and then you'll be in theatre. And now I've got some photos of the theatre itself. So I thought I'd briefly talk to you about what's involved with the operation itself. So this is your tummy, and this is your hip bone here, your belly button is here, okay, and this is the right side of somebody's tummy, the bottom right-hand corner of somebody's tummy. Where you can see the line is where we'd make the cut. Now, when we cut down, your bowels are actually in a sac called the peritoneum, and that sac is very thin, but we can move it out the way, so everything's contained within the sac. And when we move that sac out the way, we come down onto the blood vessels that go from the middle of your tummy down to your legs, okay? So that would be the iliac artery. So the artery contains blood from the heart to the rest of your body, which is oxygenated blood, and that's what the red sling is around. And then the vein, which takes blood back from your leg up to the heart, and that's the iliac vein. Now, in textbooks, the veins are always blue and the arteries are red. So, unfortunately, in the human body, it's not quite like that, but we do continue with that tradition, and we sling the artery with red and the vein with blue. Okay, so these are the vessels that will supply the kidney. Okay, the ones going down to your leg. What you can see here is the kidney being put in place, and this is the kidney up here. Okay, if you note the color, and then you'll see one after the blood's going through it and it changes, but that's the vein going in, and there's some stitches tacking it down, and obviously stitches will go all the way around. Once the vein is in, that's the artery. Okay, that's the hole in the artery of your artery going down to your leg, and that's the artery from the kidney. And again, you can see the kidney here is more white, okay, and that's a bit more the color of the kidney before it has blood going through it. When we've done all the stitching, that's the color of the kidney in the end, hopefully. It's very red, very purple, becomes a lot bigger, and that's a very nicely perfused kidney. We've made the 2 joins. There's only one more joint to make, and that's the ureter, which is the pipe that joins the kidney down to the bladder and takes urine away from the kidney and into the bladder. And very, very occasionally, we actually see urine coming out of the ureter, okay, onto the skin. And that's a jet of urine coming out. So the kidney, in this case, works straight away, which is exactly what we want to see. Doesn't always happen, but when it does, it's a great sight to see, and I call it liquid gold. So once that joint is made and you come back to the ward, what happens? Well, you have a lot of tubes and a lot of pipes coming to and from you. Most patients will have something called a PCA, which is a patient-controlled anesthesia. This is a button where you have some painkillers here, and you can't overdose, but you can take medicines as and when it will allow. You'll often have oxygen attached to you, a plastic tube going into the tummy, which will drain any fluid off, okay, around the kidney. Everybody will have a catheter in, which goes into the bladder. It's a tube going into the bladder that measures how much urine you're making and helps us work out how well the kidney is working. Most patients will also have a plastic tube, a line going into the neck, and that helps us give fluids and drugs that you may need. And again, you'll probably have a line or 2 in either hand or arm, and again, that helps us give you fluids. You also have some monitoring on that will monitor your heart and your lungs for a short period after the operation. So you'll be having daily blood tests. We will monitor your urine and how much fluids you're taking in. We'll check your weights daily to make sure that you have enough fluid on board, but you're not becoming too filled. Most centres you'll be seen by the surgeon and the medical teams on a daily basis. You may need dialysis if the kidney's not working straight away. It's about 50% may need dialysis. You will have some pain, but we'll be on top of that, and there'll be lots of painkillers available should you need it. And you'll have the input from the whole of the MDT. Okay, so you'll expect to be seen by a number of different people. We keep you busy. A common question is how long in hospital you'd like to stay, and that can really vary, and it depends. In Manchester, we're now trying to discharge patients home on about day 4. Okay, the average is probably about day 7. Okay, ranging from day 4 to 10. But it really depends on whether there's any other issues or not, and whether the kidney's working immediately or not. After discharge, you'll be seen regularly in outpatient clinic up to 2 to 3 times a week for the first month, and you have a similar sort of review every time you come in. Okay, after a month or so, things settle down. It's really, really important that you maintain this healthy lifestyle. Okay, exercise, diet, weight. Even after the transplant, it just helps maintain your level of fitness and helps prolong the lifespan of the transplant. Okay, and I cannot stress that more. There are different programs that different units have to help you maintain this, and it's something that we are working very hard on in Manchester to stress how important this is. Finally, if you want to, you can write to the donor family. Okay, ask your local transplant unit and your local specialist nurses if you would like to. Okay, but it is something that UK transplantation are trying to push now, and I think it's a very humbling experience for the donor family to have is when they receive a letter like this. So do feel free to write to them. It's all anonymized, so they can never work out who you are, and you can never work out who they are. But there are instructions on the website, and as I say, the transplant team will be able to help you if you choose to do that. Thank you very much.
Thank you. There's a lot of questions building up here.
Fire away.
brace yourself.
Okay.
I'm just going to go through them in no particular, you know, sort of in order, if you like. So this person is asking, they've got very large kidneys, but they've also got, forgive my pronunciation, diastasis recti. Would this be a problem when it came to transplant?
It may. So the large kidney, I think we'll take both separately. For the large kidneys, you need to be assessed to see whether there's space within the abdomen for the transplant. And as I said, that can be done by a scan. Now, we're doing most of our assessments virtually now, but almost everybody I know, if we're seeing somebody with polycystic kidney disease, we will see you in clinic and examine you. And it may be a short examination, but it will just confirm whether there's space within your tummy. And I think that's really important. You do need that. In our centre, we ask for yearly assessments, so we'll see you every year to check whether the kidneys have changed in size. Okay, but it can only really be done through examination, and we'd happy to take the kidney out if needed. Diastasis recti is partly to do with the stretch of the tummy because of the kidneys becoming so large, partly because of a functional loss in the strength of the muscle itself, so it can make you more prone to hernias after your transplant. But it wouldn't stop you from having a transplant by any means.
Okay, another question here, sort of survival rate of the transplanted kidney, or the longevity rather.
Yeah, the longevity of the kidney does really vary depending on the type of donor you have. The best outcomes come with live donors. Now, deceased donors can really vary between, often people give an analogy of a car, second-hand car. You could buy a second-hand Ferrari in tip-top condition that would be a young, fit, otherwise fit and well donor who's had an accident, or a second-hand Skoda, for example, who's older, has other medical problems, and those kidneys won't last as long. We would try and match donors to recipients. So hopefully if you are a 30-year-old who's otherwise fit and well needing a transplant, you wouldn't get a kidney from a 75-year-old donor, because we know that kidney's not going to last for as long as that 30-year-old will need. Overall, we'd say that the half-life of a kidney, so 50% of kidneys will last about 20 years now. Okay, and that's the best we can give, because the types of donors vary so much, but that's the sort of survival we're looking for.
So this person's asking about tolvaptan, which we've had in the UK now for about 4 years. Yeah. So have you noticed any reduction in PKD patients coming in for transplant, or is it a bit early to tell?
My experience, well, the UK experience with tolvaptan is so small. It's actually, from our point of view, too early to tell, if I'm honest. The better people be to ask are your medical doctors. So I'm afraid I'll have to defer to them. I was worried there'd be a question on tolvaptan after I mentioned it, but we just don't treat patients at that stage that would benefit from tolvaptan. So I'll ask your kidney doctors.
Can you talk a little bit about the risks to live kidney donors, living kidney donors?
Yeah, sure. So live donation is, I'd certainly say, is relatively very, very safe. Depending on which unit you're in, it's either done through entire keyhole procedure, or there's a small cut of about 7 or 8 centimeters where a hand goes in and then partly do it through keyhole. Now, there's the risk of the surgery itself, which is not dissimilar to the transplant. So pain, bleeding, infection, damage to surrounding structures. The kidney donor has a really intense workup as to see to whether they're fit enough, not just from their heart and lungs, but to check that their kidney function and their other kidney is fit enough to be able to donate a kidney. So the risk of developing kidney failure in the long term for the donor is very, very small, but it is there. Okay, and that's the kidney function required to be able to donate a kidney is stipulated to us by NHS Blood and Transplant and is dependent on age. So if you are 70 years old and want to donate a kidney, your kidney function can be a lot less than if you were 30 years old and wanted to donate a kidney. Because if you're 30, you've probably got 60, 70 years to live, and we want to ensure that one kidney is going to survive. You are slightly at higher risk of high blood pressure, and you are, because of the long-term risk of high blood pressure, in very small risk of developing end-stage kidney failure yourself, needing dialysis, given yearly, essentially an MOT, to check your blood pressure, check your blood tests, see how your kidneys are working. Okay. There is a less than 1% risk of dying through donation. Okay, so it is relatively very, very small, but it is there.
Thank you. Can you talk a little bit about side effects of immunosuppressants?
Yep, okay. So the side effects in the short term, the common ones are they can disturb your bowels. So a lot of people can get diarrhea, and that's certainly with something called MMF, okay, or mycophenolate. That can cause diarrhea, gastrointestinal disturbance. We can alter the dose of that to try and minimize it, or try other regimes. Infections is probably one of the most common. Okay, and these are not infections that would affect you or I if you weren't on those tablets, but things like viral infections, CMV or EBV, can cause you come up after transplant. Some can cause high blood pressure. Something like Adiport or tacrolimus can affect your blood pressure. It can predispose you to diabetes. It can also cause a bit of hair loss, and I think women suffer with this a lot more than men. It can cause you to suffer with hair loss. In the longer term, it's really the cancers that I spoke about, and diabetes, as I said.
This person wants to know what happens to the original kidneys, the native polycystic kidneys. Do they degrade after transplant?
No, they tend not to. If you've got large cysts in the kidneys, they just tend to remain. Occasionally, they can get bigger, but they just tend to remain in place. So we would keep an eye on them. And if you're having symptoms from them, even after your transplant, if you're really having problems with them, we can take them out, okay, to prevent you having any further complications. But otherwise, we would leave them in place.
Okay. A couple of questions that came through pre the event. So I'm very conscious of time, but there's a lot of questions. How many transplants can a person have?
That's a good question. Our record in Manchester is 5. I think the world record is 8. So it's not common. We have a number of patients that have had 3 or 4 transplants, but our record at the moment is 5.
There was another question in the group about rejection. What happens? What actions are taken if rejection starts to occur? Okay,
so there's really 2 types of rejection. There's an acute rejection, which is where the kidney function suddenly gets worse. Okay, it tends to happen within the first 6 months. If it's going to happen, that's picked up by the kidney function on your blood tests. If that happens, you'd undergo a biopsy just to make sure that it is a rejection, because we need a bit of tissue of the kidney to show that it's rejecting. You'd then come into hospital and we'd give you a high dose of anti-rejection tablets, or a drip perhaps, okay, and then see what happens. And commonly we start with steroids, so a high dose of steroids, and then if the kidney function still hasn't improved, we then give you more and more anti-rejection medicines if you need it. And that would be acute rejection. We'd hope that that would then settle down, your kidney function would go close to back to its baseline, and you'd be able to go home, probably with an increased dose of anti-rejection in the long term. The chronic rejection is really the panacea of transplantation, in that, although there's a bit we can do about it, eventually organs will reject, and there's very little we can do in the long term. We can manipulate your anti-rejection medicines to slow that progression down and to reduce that progression. But if you have a foreign object in a body for 30 or 40 years, eventually it will be rejecting very, very slowly over a long period of time. So we will manipulate the anti-rejection medicines to try and slow that and prevent that from happening.
Straightforward one here. How long's the op?
Anything from 2 to 4 hours. We say 2 to 4 hours, that's theatre time. The anaesthetic time is about an hour before then, and then you're often in recovery for 2 to 3 hours afterwards. So patients tend to be away from the ward for 6 to 7 hours, but the actual theatre time itself is 2 to 4 hours.
And question here, so someone with the left ventricle, I think it's left ventricle, I can't pronounce it, left ventricular hyper, what is it?
Yes.
How would they be managed differently during transplant?
Okay, that really depends on how bad it is. Patients with end-stage kidney failure very commonly have left ventricular hypertrophy, and it essentially means that the section of your heart that pumps the oxygenated blood around your body is baggier and slightly bigger than it should be, so it's not functioning as well. Okay, the echoes, so the scans that we do The jelly scans that we do to look at your heart will assess to see how badly that is affected. If it's only minor, then really nothing at all. We would just continue, and we'd advise best medical management with your kidney doctors and heart specialists if needed. If it's more severe, we'd get you seen by the anaesthetist, and they would assess. But we just have to be slightly more careful about the amount of fluid that we give you around the time of surgery, because the more fluid you give, the bigger and the baggier the heart gets, so the less it works. So we just need to be slightly more careful about that. There's a huge range of left ventricular hypertrophy, and it can go from very, very mild to really quite severe.
I'm just going to, we've got time for just one more question. There are loads of questions coming in. So this lady's had a liver transplant for PLD. Will she be able to have a kidney transplant if needed at some point, or are there extra things to consider?
There are extra things to consider, but you certainly will have, you're eligible for a kidney transplant. Normally, depending on where you've had your liver transplant, they may do it there themselves, or they'll refer you to your local transplant unit, and we would work closely with them. But having a liver transplant does not stop you from having a kidney transplant. Yeah,
I noticed actually there are actually quite a lot of questions regarding PLD. We did actually originally have a hepatologist talking today, but he unfortunately he had to withdraw. But we are, for anybody in the audience interested in hearing more about PLD, we've got a webinar in January. So take a look at our website, and I'm sure a lot of those questions could be covered then. But I think we are gonna have to move on. I'm sorry.
Sorry, I've not been able to answer everything. I've taken too long.
It's a fascinating topic, obviously, for anybody awaiting a transplant, or for those of us that have had them. There's still lots of questions. As we've said earlier on, if you do have any questions, please email us at info@pkdcharity.org.uk, and we'll do our very, very best to come back to you.